All right, thank you. I appreciate the introduction, Tom. Today we're going to be talking about integrating behavioral health into primary care practice. I'm a clinical health psychologist, and I trained in an integrated primary care practice as a graduate student and spent the rest of my career seeking to better understand how to successfully integrate behavioral health into medical settings. And I'm thrilled to present this topic, which I believe is one of the most important developments in healthcare in the past 30 years. Today we're going to talk about these three questions. What is integrated primary care? How are the levels of integration defined? Specifically, how does the level of integration relate to screening for behavioral health conditions like depression and alcohol? And how can you keep up to date in this rapidly evolving field? You'll be prepared to determine the level of behavioral health integration in a primary care practice, and you'll know where to go if you want to rapidly access more information related to integrated primary care and how to keep up with the latest developments in this field. So in other words, by the end of the presentation, I not only want you to have an improved understanding of integrated primary care, but I also want you to know exactly where you should go if you need more help tomorrow and if you want more information. I can't cover everything in 20 minutes, obviously, so I hope to be able to give you some high-yield resources that you can access quickly whenever you need it. So the problem facing modern healthcare has ancient roots in the separation of the mind and the body. As you probably remember from philosophy or history class, Descartes was probably the best-known proponent of dualism. He believed that the mind is the seat of consciousness and is non-substantial, and the brain is the seat of intelligence and is substantial. Hence, the brain is different from the mind, and the body and the mind were separated. And this is not just philosophical. Obviously, we all see it every day. There's a persistence of dualism in the way the healthcare system is set up. Medical healthcare is provided by medical doctors in medical settings, and psychological healthcare is provided by mental health providers in mental health settings. And it's even codified through the separation of professional practice organizations. So here in the slide it's represented by the logo of the American Medical Association on the bottom, the American Psychological Association on the top left, and the American Psychiatric Association on the top right. So you see these divisions are even systematized in the way our practice organizations are set up. Historically, even the insurance industry has been segregated with the evolution of carve-outs that are used to pay for mental health care and mental health services. The problem with this dualistic way of thinking and of treating patients and of building a system is that it's wrong. It's just, at least it's not the entire truth. The mind and the body are intricately interwoven into a whole that's nearly impossible to separate. People with mental illness suffer enormous medical comorbidity, and as a result, they die earlier than those who don't have mental illnesses. And many of those with mental illnesses are further impaired with comorbid substance use disorder, which can further compound medical illness as well. So this infographic that I presented to the right shows the prevalence of a variety of diseases and health risk factors based on whether the individual has a mental illness or not. As you can see, each of the conditions is significantly more common in people with mental illness. Even when not factoring in mental illness, and you just look at mental health disorders, they're really very common in the general population, and consequently, just based on sheer probability, they're going to be very common in primary care settings. As you can see in the slide, systematic studies show that in primary care, more than 50% of patients have had in the past a diagnosable mental health disorder. So what's the solution? As a result of all these facts, you can see that we've concluded that it's essential to treat the medical condition, the health behaviors, substance abuse, and mental illness together. They can't be separated. And integrated care seeks to provide just such a coordinated approach so that patients can be treated in a single setting for all of these conditions whenever it's possible. Integrated care generally comes in three flavors. First, it can manifest as integrating behavioral health services into primary care, such as having a psychologist or a clinical social worker on site in a primary care practice. Second, it can be the reverse. It can involve integrating primary care into mental health settings, such as adding a primary care practitioner or a nurse practitioner in a community mental health clinic or a substance abuse disorder treatment program. And finally, it can include building patient-centered medical homes. These are massive fields, so today we're going to really focus on integrating behavioral health into primary care. We're very fortunate that there's finally some hope that this is actually going to happen and is happening, because healthcare reform seeks to build parity between medical and behavioral health and to promote integrated care by funding new models of care and building new clinical resources that can help to facilitate this. So what is integrated care and what are the levels of integration? SAMHSA sponsors the Center for Integrated Healthcare Solutions, which is defined 6 levels of integrated care. This slide is a bit difficult to see, I realize, but you can find the entire slide deck from the Center for Integrated Healthcare Solutions on the CIHS website. The source is printed at the bottom of the slide, and we'll talk about it a little bit more later in the slides. Those slides that the Center for Integrated Healthcare Solution has created not only summarize the overall description of levels of integration, which is presented in this slide, but it also has 3 other slides that focus on key differentiators for clinical services, the patient experience, the practice organization, and the business models, as well as key advantages and disadvantages of each of these levels of integration. So it's important to note that there are 3 large categories, as you can see at the top of the table, and I'll review each briefly. All the way to the left is the category of coordinated care, which is the most basic level of integration. The key element of coordinated care is communication. So in this type of practice, the primary care provider and the mental health or behavioral health providers are separated. They exist in separate facilities, and at the minimum level, or level 1 of collaboration, they really don't meet, don't talk, and don't coordinate care very often. At level 2, they still are at a distance. They are located in separate facilities, but they have a little bit more interaction, and they may, for example, meet as part of a larger community on occasion. But nevertheless, this level of integration is still characterized by the separation of medical or physical health care from behavioral health or mental health care. The next large category is co-located care, and the key element for co-located care is the physical proximity of the providers. So in level 3, you see basic collaboration on site. This means that the behavioral health and primary care practitioners are in the same facility, for example, in the same office complex or the same building, but they don't actually share the same offices. So they are able to communicate a little more regularly about shared patients, usually by phone or email, very rarely in person. They may collaborate, and they may meet occasionally to discuss cases due to their close proximity, but they're not really part of the same integrated system. Most of them, for example, will have separate electronic health records. In level 4, there's close collaboration on-site with some system integration. So these are usually practitioners in the same space within the same facility, and they share some of the same systems. They may even share scheduling or medical records, and they communicate in person as needed, and they can collaborate as needed for consultations and coordination of difficult patients. So they have an increased understanding of the basic roles and culture of each of the primary care and behavioral health roles. The highest level of integrated care is the 3rd category of integrated care, and the key element is practice change. There are 2 levels. Level 5 is close collaboration, approaching as an integrated practice. So this is when the behavioral health and primary care practitioners are in the same space within the same facility, so they have some shared space. They actively seek system solutions together. They may actually have integrated workflows. They communicate frequently in person. They collaborate often. They have regular team meetings to discuss the overall patient care and specific patient issues. and they have a real strong understanding of roles and culture and have pathways of communication that are well established. The highest level is level 6. This is full collaboration in a transformed or merged integrated practice. The practitioners are in the same space, in the same facility, and they share all the same spaces. They have resolved most or all of the system issues, including functioning as one integrated system so that the pathway of communication and referral and sharing of medical records and of information on patients is very well integrated. They are in consistent communication. They may even meet with the patient or the patient's families as a team. They often collaborate and have defined roles for most patients. They have formal and informal meetings to support the model, and they have roles and cultures that are blurred or blended so that they often share responsibilities rather than having a very hard and fast silo between the practitioners. So that's an overview of what integrated care looks like and what the commonly accepted 6 levels of integration are. Let's talk briefly about the key points for behavioral health screening, specifically depression and alcohol, which are relevant to the G1 task. The current state of integration of a practice, or the level of their integration, is likely to be associated with the acceptability of routine screening, because the lower level of integration, the more resistance there'll be, because the practitioners, the primary care practitioners, will fear opening Pandora's box. Now, this is a legitimate fear. Clinicians are afraid that if they ask the questions or they screen, then they're going to have to address the patient's answers. And they either feel ill-prepared to do so, either because they're not trained to do so, or don't have other resources readily handy to help them with it, or they just feel too much time pressure to deal with a positive screen. So if a person that screens positive, they didn't have to deal with it, and it bumps the rest of their patients if it takes too long. So in sum, the fewer the behavioral health resources on site and the lower the level of integration, the more this fear of Pandora's box will be present, and it will be a strong disincentive to screening. So it has to be attended to if you're going to promote screening in a non-integrated practice. Regardless of the level of integration, so if it's low or high, structured clinical protocols are really important to support screening and management of behavioral health. So you have to answer the questions: who will perform the screening? Will it be the medical assistant or the physician, for example? How will the screening be performed? Will it be paper and pencil, interview, or computerized? Where and when will it be performed? Will it happen before the patient is brought back to the treatment room or upon treatment room placement, for example? What will happen if the person's positive? What additional assessment is required? What treatment protocols should be followed? What behavioral health resources should be provided? So these are some key questions that will need to be answered and memorialized in a protocol so practitioners can be trained and so that they know exactly what needs to happen when a person screens positive and has a behavioral health condition. Electronic health records are really important to support this effort. So, when possible, integrating the screeners and the other assessment instruments into the electronic health record, linking them to best practice alerts and clinical decision support tools, and building in patient resources into the EHR can be really important. And we're fortunate because there's been much activity around this in the major electronic health records throughout the country. And often templates and flow sheets can be found that can be used as a roadmap for doing this. So in other words, the practices don't have to reinvent the wheel. Often they can simply look to the electronic health record resources and talk with folks who represent the electronic health record, and they can find protocols that can be shared by other sites. Another point to consider if the practice is in a low level of integration is that the primary care clinician may need to provide more first-line treatment. So, for example, in a depressed patient, if there's no behavioral health provider on site, the primary care practitioner may be more likely to prescribe antidepressant medications for those patients because they have to manage them alone. So those sites will also have to develop a mental health and substance abuse treatment referral list because they want that information handy to give to patients, and it should include information on local self-help resources like 12-step groups when possible, because many patients won't want to seek formal help or won't have formal access to professional help available, but may actually be able to access local self-help resources like AA groups. Of course, these resources are highly dependent on insurance, so ideally the list should be organized accordingly based off of what insurance is accepted. And because of the complexity of this, many clinicians will simply have the habit of telling the individual that he or she should simply call his or her insurance to find mental health treatment resources. This is, I guess, acceptable, but in these situations it's probably still useful to provide a referral list and to provide information on referral and helplines when possible. Most states will sponsor referral mental health or substance abuse referral and helplines. So just because a practice has a high level of integration, their behavioral health and primary care practitioners working in conjunction with one another, it doesn't mean that they're not going to experience barriers. Most of these high-level integrated practices will still need to focus on efficiency of referring when a person is identified, establishing clear communication, clarifying roles and responsibilities, and exploring the financial sustainability of their model, which can be a real challenge. Also, it's important to remember that mental health providers need specialized training in integrated primary care. You can't just find a clinical social worker or a clinical psychologist who's not been trained in integrated primary care and just plop them in a clinic and expect it all to work out. There are specialized training programs for this role. And notably, what I've noticed is that even if a setting has high integration and they may have strong experience with depression, they often don't have experience with alcohol. And this is because historically depression has had a better traction with physicians because there are safe antidepressants that can be prescribed to patients. So the prescription of antidepressants by primary care has evolved over time to be a very acceptable practice. Also, depression has been part of pay-for-reporting and pay-for-performance programs, so screening for depression and monitoring depression has been incentivized by the health industry. But both of these factors, the ready prescription of medications for the disorder and the pay-for-reporting, really haven't characterized alcohol as much. So you may see that even in integrated practices, they will need to really work on this alcohol screening protocols. So those are some of the main points to remember when working with sites to integrate screening and based off of their level of integrated care that's present at the site. So now what I'd like to do is turn to providing you some high-yield resources for integrated primary care. And we're very fortunate that there are really great resources for learning more about integrated behavioral health. SAMHSA supports the Center for Integrated Health Services, which I mentioned earlier, and they have a fantastic website with plenty of information, links, and free downloads that they actively promote as shareware. So you can download the PowerPoints and you can copy them and you can even just present them de novo. So they've made it really easy. It's very user-friendly, it's easy to digest, and I highly recommend visiting if you have any interest in learning more about integrated primary care. And also, as time progresses, if you want to find out the latest developments, they often will have newsreels and other information on cutting-edge practices. One resource that's on this site that I wanted to mention, but I didn't review it in our presentation because I didn't have enough time, and it's a little complicated, is a really great tool. The link is at the bottom of the slide. It's an interactive flow sheet that will walk a clinic through the key questions to ask about integration, and it identifies and helps the clinic to determine pathways and resources that it should focus on based off of the answers to those key questions. So it basically can help the site to do a readiness evaluation and prepare some approaches for how integrated care can evolve in that practice. second high-yield resource that I want to talk about is AHRQ's Integration Academy. The website is not as well developed as SAMHSA, so it's a little clunkier, but it has some unique resources that the SAMHSA website, the Center for Integrated Health Solutions, doesn't have. And in particular, I wanted to call out the map of integration activities in the U.S., the lexicon of terms, because once you really start to dig deep into integrated primary care, you'll realize that there are many terms that are specific to that field, and it can get confusing quickly. So the lexicon is useful to just have handy. And what I found really helpful is the EHR case study. So remember earlier we talked about using the electronic health record to really support and facilitate integration. The site has health informatics case studies which summarize exemplar EHR programs that can support integrated primary care. I like it because it really puts it into a tangible picture, so you can picture and imagine exactly what these programs should look like. Finally, there's another high-yield resource that the Academy produces. It's the Guidebook for Professional Practices for Behavioral Health and Primary Care Integration. And it's also great because it uses several case studies of successfully integrated care. So it takes, once again, those abstract concepts and all these principles and puts them in a really accessible way by describing some high performing healthcare systems throughout the country that can be used as exemplar role models. So in summary, an individual primary care practice may fall along a spectrum of integration with behavioral health, and this is likely to be an important factor in a practice's willingness to embrace behavioral health screening like depression and alcohol screening. But regardless of the level of integration, it's important to build clinical practice protocols to standardize the particulars surrounding screening and how to handle positives. That's important whether they have no integration practice and no behavioral health resources on site, all the way to behavioral health and primary care working side by side in the same shared space. SAMHSA and AHRQ sponsor fantastic websites with detailed current information that will make it easy to keep up with this evolving field. So I wanted to remind everyone that these links and others already appear in the resource guide that we've shared for the G1 task. So if you can't access the links through the slides, you can find these links in the shared drive in the resource guide, and they should be accessible there. All right, thank you for your attention. I appreciate it.